Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment.
Okay, welcome back to the OrthoZone Podcast, brought to you by Tri-County Orthopedics. This is going to be part 2 of a 2-part series with Dr. DiPrinzio, where we talk all things elbows. Last time we talked elbow anatomy and elbow fractures. Today we are going to talk about sports elbow injuries and then elbow arthritis. All right, so welcome Dr. DiPrinzio back to the podcast.
Hi, thanks for having me back. Excited to talk more about elbows today.
All right, so let's jump into sports elbow injuries. The first thing we're going to talk about today is elbow dislocation, if we want to start there.
Sure. So in our last talk, we talked a little bit about elbow dislocations when they happen during a fracture around the elbow. And I would say that in sports, especially in like the younger population, sometimes there's no break at all, and the only thing you get is a dislocation of the elbow joint. This happened just recently to Jaden Daniels of the Commanders in the NFL. So in this case, the elbow joint dislocates, but no bones are broken. So what we do is we actually put the joint back in place, just like many other joint dislocations, and we keep them immobilized for a short period of time. And since none of the bones are broken, those bones provide pretty strong support to keep that elbow in place, and we can range and move these elbows very quickly after the injury. So in my practice, I'll usually do a sling for 1 or 2 weeks, maybe a splint or protective device just to kind of help with pain and swelling early on. And then we try to get the elbows moving even after just a few weeks. Sometimes we use something like a hinged elbow brace. Many times people have seen these hinged braces for the knee, very similar when it comes to the elbow. Surgeon preference for when people return to sports or activities is very variable when it comes to elbow dislocations. In my practice, 6 to 8 weeks would probably be the earliest I would consider something like that. It would be very dependent on the patient in terms of how well their range of motion was recovering, as well as their function and how comfortable they felt returning to their sport. Certainly this could go up to 3 or 4 months if they have a high demand in terms of their sport, or if they're still having some persistent soreness or stiffness.
What would cause an elbow dislocation for someone?
It's usually a hyperextension. So a lot of the time someone will kind of put their arm out straight and then their hand will get pulled backwards. It's very difficult to dislocate the elbow in flexion or when the elbow is bent. Usually if that happens, you're going to have a fracture along with the elbow dislocation. And I would say in the general population, if you're dislocating your elbow, you probably do have a fracture that goes along with it. In sports injuries, because sometimes they're a little bit higher energy or the elbow is put in a position that's a little bit more unusual, there's a higher risk that you may just have what's called a simple elbow dislocation or elbow dislocation without a fracture.
Now, obviously, it can happen in athletes, but it can also happen in just other people as well.
Yeah, it certainly could happen in anyone in the general population. I would just say I more commonly see this in athletes probably because of the positions and the sports that they're playing.
Right. And for the most part, if someone's dislocating their elbow, they're going to go right to the hospital, right?
Yes. And if you have very skilled medical teams, like, if there's a physician around the game when you're injured, if this is a sports injury, a lot of the times they may be able to put the elbow back in place even on the field or on the sideline, but many of these end up going to the emergency room to have the elbow put back in place. I do think this is somewhat of an emergency. While, it doesn't need to be done within an hour, it probably should be put back in place within the same day to be able to have a good recovery.
And even if you're not fracturing the bones in the elbow, are you at risk for further injury in the future having dislocated?
The research would say no. So in general, simple elbow dislocations recover quite well. The one thing that I would say is that stiffness is quite common after any type of elbow injury, elbow dislocation included in that. So persistent stiffness, later on in life, that could certainly be the case. If there is an underlying additional injury, like a cartilage injury at the time of the dislocation, yes, there's a higher risk of arthritis down the line. But in general, there is not a lot of evidence to say that a elbow dislocation without fracture that gets put back into place quickly and recovers well should have a lot of issues later on. Probably that patient will do quite well.
Let's move on to ligament injuries in the elbow.
Sure. So as we talked about in the anatomy part of our last talk, the elbow is a very complex joint. There's multiple ligaments that confer stability to the elbow. So I'm not going to go into every type of ligament injury that there is. I tried to pick something that's a little bit geared towards sports and very popular, and that's mainly baseball throwing ligament injuries. So I see this most often in the elite middle school, high school athletes, in college throwers. I don't see professional sports as much in my practice, but certainly that's something that can come up as well with professional baseball players. So as we talked about in the last talk, the elbow is a very complex joint. There's multiple ligaments that confer stability to the elbow. So I'm not going to talk about every type of injury, but one that I think most people have heard of, that gets talked about a lot, and that I at least see a lot of patients for, is the ulnar collateral ligament at the elbow. Sometimes that's called the medial collateral ligament. A lot of people know it as the Tommy John ligament. So many times this is related to baseball throwing injuries. In my practice, it's mostly elite middle school, high school athletes, college throwers. I don't see professional sports players as much in my practice, but that's certainly something that we think about in terms of baseball pitchers. Sometimes I have to remind myself and even others that it's not just baseball players that get this injury. This can happen in football quarterbacks. This happened to Brock Purdy a few years ago, and it can also happen in, track and field athletes, javelin throwers, and even non-throwers can have these injuries. Wrestlers, gymnasts, anyone who puts a lot of stress on their elbow can have an ulnar collateral ligament injury. It's just most common to see in throwing athletes. Another thing that I try to remind people is that, especially in throwers, partial tearing of the ligament or even just strain of the tendons around the medial elbow is probably more common than a full tear. So there's a lot of patients who are concerned that either themselves or their family member has this injury, and a lot of what I see ends up being ruling out a more significant injury and getting these patients into rehabilitation programs, physical therapy, and often pitching rest, complete rest from pitching for a few months to try to get their elbow back to its baseline.
For those who tear their UCL, is it always going to mean surgery, or can they rehab it and not get surgery?
Sure. So in the non-throwing athlete, I think that rehabilitation is a little bit more common, although it's very dependent on the patient, their level of sport, their expectations for return to sport. So in general, you can treat a torn ulnar collateral ligament non-operatively. There's always a risk that that may not heal appropriately, and then you may have to go on to surgery later. But there are certainly programs and physical therapy programs that are focused on rehabbing ulnar collateral ligaments non-operatively. When it comes to surgery for the ulnar collateral ligament, for many years since its invention, we have been kind of replacing or reconstructing that ulnar collateral ligament. So that's where the name Tommy John came from, because this was famously performed on him. And the reconstruction of this ligament is really necessary for these long-term throwers, typically those professional pitchers who've been throwing for many years of their life. They have a type of injury to the ligament where it kind of stretches out over time. It may be completely degenerated. It may ultimately tear, but it's usually after years of minor injury. And that ligament is not necessarily healthy enough just to fix. So many times you'll have to perform a reconstruction. What has become a little bit more popular recently is actually repairing that ulnar collateral ligament. So a lot of people that have been talking about orthopedics or know something about orthopedics know that people have been thinking about repairing ACLs. This is a somewhat similar situation in terms of the elbow, where in younger individuals who may have had an acute injury, like, I just threw a pitch and my elbow started to hurt, or maybe in wrestlers or gymnasts who had a traumatic injury, a lot of the times just one end of that ligament was pulled off of the bone. And if the patient chooses to have surgery, typically early on after their injury, you can take that end of the ligament and repair it to the bone.
So a repair of a ligament is just reattaching it, and reconstruction is creating a whole new ligament?
That's exactly correct. So a repair of a ligament is using your native ligament or the ligament that was injured and reattaching it. A reconstruction is using a different type of tissue. Sometimes it's tissue taken from your own hand or wrist. That's probably the most common graft that we use for a reconstruction. And sometimes it's a cadaver ligament that we use for a reconstruction. But either way, you have to use something new, because the native ligament has been too injured to repair.
What does rehab and return to sport look like for UCL repair?
So traditionally, UCL reconstruction would take about a year to return to sport, and that's been a little bit accelerated with UCL repair. Now we're talking more like 6 months to get patients back to their sport. I think of late, even UCL reconstructions have been moving towards a similar time frame to return. But I think one thing you have to remember is the patients that are getting UCL reconstructions are typically those long-term pitchers, professional athletes. And while they may be able to start throwing at a similar time that a UCL repair patient may be able to start throwing, it will probably take that elite professional athlete longer to get back to their elite form than maybe an elite middle school or high school player that has this surgery.
So for the most part, do you know if in the MLB, the pitchers they're usually getting a reconstruction versus a repair?
I would say that most MLB pitchers are going to be getting a reconstruction because, again, their ligament has been injured over a very long period of time of throwing. Whereas typically when I see this in an elite high school player, they would have almost an acute injury where maybe they throw really hard one time and their ligament detaches from the bone.
All right, now let's start talking about tendon injuries around the elbow.
Sure. So the two main tendons around the elbow are the biceps tendon. So that's the tendon in the front of the elbow that bends or flexes the elbow, and the triceps tendon, which is the tendon in back of the elbow that extends or straightens the elbow. I'm going to talk about the biceps tendon first, probably because this is just a little bit more common. And again, similar to UCL injuries, it is very common to have either tendonitis or partial tearing of the distal biceps tendon. And for me, these are almost treated exactly the same because they're very similar pathologies. The tendon is not torn off of the bone. Maybe there's some fraying or inflammation within the tendon itself. Maybe it was stretched but not completely torn. And the vast majority of these patients do not end up needing surgery to treat that. It can be treated with activity modification and physical therapy. I do warn them it may be about 3 to 6 months until they have a full recovery. But again, many biceps tendon strains, partial tears, tendonitis don't end up needing surgery.
And for the bicep tear or strain, is that usually from like long overuse, or is it like an acute thing?
So tendonitis is typically an overuse injury. So I'll see this a lot of the times in weightlifters or manual laborers. Partial tears can be either. Sometimes I'll see a patient who has been having pain for 6 months from weightlifting. Sometimes I'll have, a regular dad who is picking up their kid and ends up feeling a strain in the front of their elbow. So I would say that it can be either of those. More important to differentiate a partial tear and tendonitis from a complete tear because that is a little bit different of a treatment plan.
Right. And then what happens with a complete tear of the bicep?
So complete tears of the biceps are also fairly common. This usually happens when someone is trying to lift something heavy and firing or activating their biceps, but instead of their elbow flexing, the elbow gets extended. So for example, if you're trying to lift a heavy box and then place a heavy box on the ground, as you are lowering that box, you are still using your biceps quite a bit, but your elbow is actually extending. That puts a lot of pressure on the biceps tendon, and that's typically the mechanism of how these tear. It happens a lot in young middle-aged patients and even in late middle-aged patients, much more common in males. And the way that we treat these is typically based on the patient. So for those young middle-aged patients, we often fix the biceps tendon or reattach it to the bone, just because this gives them a very reliable recovery to their previous function. The things that we worry about in terms of not fixing the biceps tendon. So fortunately, there's other muscles of the arm that can bend or flex the elbow. A lot of strength is actually kept even with a ruptured biceps tendon. The biceps is actually the strongest muscle that supinates the hand. So as we talked about last time, supinating the hand means having your elbow at the side and going from palm down to palm up. And that's actually the main job of the biceps tendon. So if you rupture the biceps tendon, sometimes even up to 50% of your supination strength can be lost. So for a manual laborer, an active young individual, that will be very noticeable. Now, on the other hand, an older individual or someone who is not physically active will probably not note these deficits as acutely. And many times these patients will still opt for non-operative treatment. And other than the cosmetic deformity of having a little bit of a bunched up muscle, they'll have a very good recovery.
So what does the surgery look like for bicep repair?
So in my practice, I will do an incision over over the front of the forearm area, because although the biceps muscle is in the upper arm, its attachment is actually deep in the forearm. So it's a single incision. We dissect down to the bone, which is the radius that the biceps is attached to. We find the attachment point and clean it of any tissue. Then we find the ruptured end of the tendon and reattach it to the bone. Sometimes after the biceps tendon ruptures, it will retract very far up the arm. Sometimes this requires a longer incision or even a second incision higher up the arm to find that tendon and reattach it to the bone. Sometimes I see these patients further out from their initial injury, and when it's been a month, 2 months, 3 months, I'm not always able to pull that biceps tendon back down to the bone, and in those cases I have to use a little bit of tendon graft. Fortunately, although the recovery is maybe a little bit slower with a tendon graft patient, they tend to do quite well after their full recovery also.
What does the recovery look like?
So after a biceps tendon repair, I do try to protect the repair for a few weeks. That might either be splinting and not moving it at all, or maybe using a hinged elbow brace to prevent certain motions. Typically, I don't want them to fully extend their elbow right away because that can put a lot of strain on the biceps tendon. Usually after about 6 weeks, I try to remove any restrictions in terms of their motion and start doing some light strengthening. And then at 3 months, the biology of that tendon should be that it's reattached to the bone, so we can start strengthening without restriction. So for those heavy manual laborers or people who are doing heavy weightlifting or sports, I'm typically talking about a 3 to 4 month return. If you are a heavy weightlifter, 3 to 4 months is when you begin that really strong strengthening process. You may not return to your full strength for 6 or 9 months or a year after a biceps repair, but again, the recovery is very reliable, and I do think that everyone will get back to their regular function after a biceps repair.
So there's never going to be like a weight limit restriction?
Once the biceps tendon is healed, it should be nearly as strong as a native biceps. So there really is not any long-term weight restrictions once the biceps tendon is repaired.
Let's go to tricep injuries.
Sure. So triceps injuries, again, it's the tendon that straightens the arm. Again, triceps tendonitis, more common than just tearing. Many times I'll see this in young weightlifting patients. And again, these tend to heal very well with physical therapy and non-operative treatments. Complete tears of the triceps are much less common than the biceps, similar in terms of an over heavy weight kind of pulling on the arm while the triceps is activating. The big difference with the triceps is that the triceps is really the main muscle and tendon that straightens out the arm. So without the triceps, people are significantly weak in trying to straighten out their arm. There really isn't a backup muscle or tendon that can do that. So often these go on to surgery, even in the later middle-aged patients, because otherwise they would have persistent weakness in using their arm. Again, thankfully, these patients do quite well once that triceps tendon repairs and you go through the rehabilitation process. And I would say that my rehabilitation process is very similar post-operatively as to the biceps repair that we just spoke about.
And is the surgery itself similar?
It is similar. It's a single incision, but this time it's on the back of the elbow. Often the triceps does not retract as far as the biceps tendon can, so that tissue is readily available to put suture or stitches into and then reattach it to the bone at the back of the elbow, which is called the olecranon.
Would you say that you see more bicep or tricep injuries?
I do think that bicep injuries are just more common, so I'm seeing that more often.
All right, let's get into elbow arthritis.
Sure. So I think elbow arthritis is a interesting topic because it's different than arthritis in almost any other major joint of the body. So when you're comparing it to hip, knee, or even shoulder arthritis, the situation is a little different. The elbow is not typically a major weight-bearing joint, so arthritis is just not as common as it is in the lower extremity. Another way that the elbow differs from other joints is actually the shape or morphology of the joint. So in the last talk, we talked about how the elbow is somewhat like a hinge. So the humerus or the upper arm bone ends in kind of a rounded cylinder or spool type shape, and the ulna is almost like a rounded cup that goes around that cylinder. So this is different from the hip or the shoulder, which is more like a ball and socket type joint. So in early elbow arthritis, that cup part of the hinge will start to wear down the cartilage and build up some bone spurs or extra bone, specifically in the front of the elbow elbow joint and in the back of the elbow joint. And how this presents in a patient is that the elbow can still move fairly well through the mid or normal areas of motion, but when they're trying to get all the way up or all the way flexed or all the way straight or extended, they're having pain and limitations on these endpoints. Similar to arthritis and other joints, I often perform corticosteroid injections and physical therapy, but I don't find it to be as helpful for those patients that I just described where they're actually having a mechanical block to the ends of their motion.
So when you're diagnosing someone with elbow arthritis, can you see the cartilage worn down on an x-ray, or is that something you have to get an MRI for?
I do think x-rays are always the main and first study that I will get in terms of elbow arthritis. The x-ray will be able to show the bone spurs, and the bone spurs are a sign that the cartilage has been worn down. So even though you can't visualize cartilage on an x-ray, often there are signs that the cartilage has been worn down. And more importantly, you can get an idea of where the bone has built up over time, because that's really what's causing the limitations to their function and their motion.
What is your first line of treatment for elbow arthritis?
So first line would still be non-operative means, cortisone and physical therapy, but again, that mechanical block may not improve much with non-operative treatment. So if someone has early elbow arthritis, like we just talked about, where it's just the front of their joint and the back of their joint, many times this can be treated arthroscopically. So with small incisions and cameras and instruments, they're inserted into the elbow and you can actually shave down the parts where the bone has been overgrown. Sometimes I'll make an extra small incision to remove extra bone, or maybe move a nerve out of the way to be safe, or even release a nerve if people are having nerve issues as well. But in general, most of the surgery can be performed arthroscopically. I think that's another really interesting topic, because arthroscopy for arthritis is not really used in many other joints of the body. It hasn't been shown to really have prolonged good outcomes. But in the elbow, arthroscopic clean out procedures, or what we call debridement, actually work quite well at getting people some range of motion back and feeling like their elbow is working more like their regular elbow.
So what percentage of people with elbow arthritis, like once they do the arthroscopy, it's fine for them? They don't need to do anything else?
I would say that it is good for them for a period of time. And, in general, when you use arthroscopy for arthritis in large joints, that period of time will not be very long. But in the elbow, sometimes that period of time can be 5, 10, or even more than 10 years. So I do think there is some long-standing relief from addressing these problems, even with arthroscopy.
And then what about with patients who have more severe arthritis?
Sure. So there are certainly those patients who have pain throughout any range of motion of their elbow and are quite limited. Sometimes arthroscopy can still be employed in those patients. Many of them will have large loose bodies of bone or bone spurs that have broken off, and they can be removed or cleaned out using an arthroscopy. Many times once the arthritis is too severe, I'll have to treat it with an open incision, and that still is the procedure of cleaning out or debriding the elbow, but with an open incision I can be a little bit more comprehensive in the area of the joint that I'm addressing.
So I know a lot of people know for like hips, knees, shoulders, replacements and how successful those are. Is that the same for an elbow replacement?
So there are elbow replacements. It's very similar to the other joints where it's metal and plastic that's replacing the arthritic bone. The way that this differs is that elbow replacements are not as reliable in the long term as the replacements for these other joints. So many times nowadays for these large joint replacements, we're talking 15, 20 years or more of implant viability. When we're talking about the elbow, the complication rate is much higher and the longevity of the implant is much lower. Complications include wound healing, infections, and loosening of the implant. And the longevity of the implant may only be 5 to 10 years at times. So many patients who are having this at a very active or younger age will probably require at least one reoperation in their lifetime for their elbow replacement. The other important factor to remember is that after an elbow replacement, there are restrictions to what you'll be able to do with your arm. There is a weightlifting limit, and many surgeons will use that limit as about 5 pounds for the rest of your life, and that's what I use in my practice as well.
So what would happen if you picked up something that was more than 5 pounds with your elbow replacement?
I think the main risk is that because the bones are smaller and they're not weight-bearing joints in general, the fixation of those elbow replacement implants is not as strong. So that's why these elbow replacements tend to loosen in an early fashion, and the more heavy weight you're lifting, the more activity you're doing with your elbow, the earlier that implant is going to loosen. reason.
And then what's a situation where you do want to use an elbow replacement?
It's always a discussion with the patient and a long consideration, because even when you do these in the right situation, that complication rate and revision rate is still high. So sometimes we do these for people who break their elbow. So like in the last talk, we talked about distal humerus fractures. Sometimes the fracture is just not reconstructible. It just can't be fixed, especially in the older patient who may already have elbow arthritis and then break their elbow. That may be a good candidate for an elbow replacement. Also, patients with rheumatoid arthritis or other inflammatory arthropathies, I would usually try to treat them with an arthroscopy or a clean out procedure first, but if that didn't really relieve their pain or they had recurrence of their issue, then we would certainly talk about the subject of elbow replacements.
Wrapping up, do you have any other thoughts about elbow arthritis?
So again, in general, elbow arthritis is interesting to me because it's different than arthritis in other parts of the body. I like doing arthroscopy for these patients, especially in that young patient who may have very early arthritis, and maybe it's just a few loose pieces of bone that are causing them an issue, or just a small area that needs to be shaved down. It can be very satisfying for both the surgeon and the patient to have a smaller procedure with a very fast recovery and get back to your regular life quickly.
All right, so I think that's a wrap on our elbow series with Dr. DiPrinzio. Thank you for coming on.
Thanks so much for having me.
And we hope you learned something.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.